unobstructed PA flow and they don't have too many issues. So yeah, they're able to, a lot of them are able to manage.
Okay, and then my last case is another cool case, and I'll be curious if anyone's ever seen this before. So we saw this come through, and you can see this patient has an aortic stent valve. They've had a sternotomy. There's some edema, and we saw this over here. And you know, these all, I don't know about you guys, but the valves are getting harder and harder to see. But this is part of the markers on the sewing ring, and this looks like some of the valves I've seen, this with this sort of wavy looking thing, but it's in a very non-anatomic location. We didn't have a lateral, and at the time we didn't have any cross-sectional anatomy. So we didn't know where this was, but if there'd been some kind of shunt or something made there. But luckily for us, even though the patient was in florid edema, someone decided the patient must have a pulmonary embolism as well. And so we got a really nice contrast enhanced CT. And what we see is right here, we see this graft coming off the left atrial appendage and going, there's a valve in it. That's what we saw in the radiograph, and it goes right into the left ventricular apex. So this is a left atrial, left ventricular shunt, and you can see there's really heavy mitral annular calcification there. And so, and there's the stent valve. So they were unable to do, and then this was a patient somewhere else before they were transferred here for something unrelated, but they were unable to do a mitral valve replacement for severe mitral stenosis. So they did a bypass graft, and I've never seen this done before, but I did find at least one paper of this showing this specifically for this. They went to the ascending, they did a different one, but these grafts, you can see there's the valve in the graft there, and then it's a different one in particular, but they can, so it allows one-way flow. So if we go back here, so that way, that when the left ventricle contracts, it doesn't squirt blood back into the left atrium, but rather this valve shuts and then blood goes out the aortic stent valve now into the systemic circulation. So there's some old extra anatomic shunts they did, I think, for some of the congenital heart disease, but I've not seen this done for an acquired mitral stenosis. I don't know if anyone else has ever seen this.
Nope.
That's my first.
Okay.
Wow. I would have been absolutely perplexed with this one.
Well, we just knew the patient had had some heart surgery, but yeah, I'm glad we had the CT because it made it clear what they had done, because it was a long time ago and it wasn't here, and it also just made for a nice case. So never surprised by the fancy plumbing they do. And that's all the cases I have currently. All righty.
I can go, Jeff.
All right. And then Travis is on too. Good. I still don't see David, so.
So this is just, let's see if I can look at the dates here. Go. So this is a patient with, you can see metastatic disease in the liver. Not the best study to assess the right heart valves, but they looked okay here. And then this is the patient a year later. You can see the Mets are getting worse. And maybe start, you should really rarely ever see the tricuspid valve. Pulmonic valve, But then on the most recent study, as the carcinoid Mets have continued to get worse, you now can see that not only is I won't go back and show you, but the heart size is a lot bigger. Again, this is part of the tricuspid valve, which really should never see it. The right atrium is pretty darn big. And then you can also see quite marked thickening of the pulmonic valve. So this was a patient with carcinoid syndrome. I'm sorry, who had metastatic carcinoid, who had, the serotonin release into the IVC and then leading to valvular fibrosis. So I know people have shown some nice cases, but it was just showing the progression over many years. And again, you should rarely ever see the pulmonic valve on imaging, let alone, you can see how thick this is on this study, the 3 leaflets, and the tricuspid valve as well. So, and here, just go back real quick and kind of show the progression of the heart abnormality. So, you know, back here, the heart was completely normal initially, and then now the RV and RA are definitely not normal. So just a nice progression of valvular heart disease due to metastatic carcinoid. I don't remember what this case was. Oh, this is an interesting case. I'm curious what you guys think about this. So this was a patient who had this kind of line here, and it was called chronic PE, which is you kind of understand, but I'll show you the next study. So there's this kind of weird low attenuation line. Let me go back to the prior study. So the prior study, you can actually see the same line is now during the systemic arterial phase is due to arterial inflow from this there's this strange area of scarring here. You can see the kind of parenchymal destruction, bronchiectasis, scarring, and there's this intercostal artery, pronounced intercostal artery hypertrophy here. And one of these big intercostals is somehow anastomosing with the pulmonary artery, and we're getting regurgitant flow from the higher pressure systemic artery into the PA here. And again, just show it to you during the pulmonary arterial phase. Where we're getting the same thing, but it's kind of, you know, smoke. But has anyone seen something like that before?
I have 3 of these now. I showed one a couple months ago, and a couple years ago I had one with the catheter angio that showed the flow.
Yeah.
What was this one from? Is it old TB or something?
We don't know. We just have 2 studies on them.
Yeah.
The whole area looks, you know, it's quite scarred down. I don't know if it was TB or not, but clearly some sort of infection.
Yeah. Yeah. Well, maybe we should write these up. We've got 4 of them now.
Yeah. I mean,
and it's great that you have the two different phases, because you're right. There was the most recent one I had from here was like the outside hospital said they didn't think it was PE, but they weren't sure.
Yeah. No, I mean, I think you would be without having the prior, because, you know, overnight this was called chronic PE, which I'm happy they kind of saw it, but you would say, okay, you know, there's a little web there, and then you go and you can't see the artery. Maybe that's, you know, the posterior segment artery is kind of gone. Maybe it's chronically occluded. Anyways, yeah, it's just interesting. Okay. So.
Well, and the issue too, like if they did a VQ scan on that, because the fact that the flow is reversed,
oh, yeah.
then it messes up the VQ scan too, and then they're likely to call it PE as well.
Yeah.
Yeah.
No, okay. Well, we should, maybe do a small case series, because it is kind of neat.
Yeah.
And you think it arises from an intercostal artery that
somehow there's some sort of.
They were huge. Yeah.
Yeah, and this year they're really big. I mean, you can see there are just big intercostal arteries here, and you can actually see them go kind of into this. You know, they can't find the exact connection point, but
I see it there now. Yeah.
Intercostals. There's the tenting here, and then all of a sudden you're getting a arterial blush, and there's no other point in this, you know, where you're getting any systemic arterial or any pulmonary arterial blush. The pulmonary arteries are unapacified, so it's coming from the systemic flow. And just because of the scarring, I don't know if it's a fistula that develops, and then because of the fistula getting more even increased flow because you're getting high pressure to lower pressure. I'm not sure. But all your cases happen with areas of scarring, correct? I'm guessing.
Well, one of them was trauma. I can pull that one up. That was one from UCSF. I've actually just reloaded the one from here that I'll show after you're done. For the most recent one I've seen. And because, yeah, Seth, I'm curious what you think about what caused, and I don't know if Howard saw this one either, just what you guys think is going on in the lungs anyway. But yeah, there's definitely abnormal underlying lung.
Boy, that's interesting.
So this is the last case, and the thing that, I mean, was a little, so this is a guy who came in, had severe chest pain, has this large filling defect, kind of soft tissue creeping along the wall. I think kind of people understand where we're going with this, but the interesting thing was he was treated with anticoagulation, and this is where you can kind of get into a little bit of trouble. Oh, sorry, so here he was initially. He was treated with anticoagulation, but then he developed multiple acute PEs on the right side that actually went away on subsequent imaging. So in subsequent imaging, those areas back here, like this acute PE, went away. And then there was another area of PE. You can see this one here. They had went away. There were a few new areas of PE. Lower extremity ultrasound was negative. So this is the first study here on the bottom right. This is the second study. You can see that this area here is unchanged, but the actual central clot with stuff creeping along the walls is actually better. Then the follow-up showing multiple new acute PEs. The PEs here resolved. There are multiple new acute PEs. Anyways, we were kind of confused by this. I said, you know, this here is obviously quite concerning for sarcoma, but I can't, you know, non-resolving PE with just a very dilated vessel. And we were trying to figure out how the other PEs developed. And our assumption is that, you know, this clot, the sarcoma started, you know, probably down here, and clot just sits and kind of propagates centrally due to the obstruction. And presumably some of that clot must just get over onto the other side. It just must break off and then flip over to the other side. But the interesting thing about these cases as well is to realize how much of this is really tumor beyond the, and the other thing that you think, oh, well, you know, it's very common to see very classic signs of chronic PE with these sarcomas in non-involved areas. So here you can see this was all sarcoma, but this stuff down here looks like classic CTEPH, right? The vessels just go away. And that's something we see a lot with these ones that kind of predominantly go into one area. But the interesting thing is really how extensive these are. It's hard to appreciate that these all grow along the wall, grows along the roof. It's even growing along the other PA, along the other right PA. And so we said it's, you know, going to be a sarcoma, but it's kind of strange, and we wonder if there was kind of a clot associated with it. But this was, I don't know how to make this thing bigger on here, but this was pretty much all on when it was taken out. So here I can't blow this up, but here's that big central portion here. And this stuff is the left lower lobe stuff. And that's all, there was no sarcoma here. This was all CTEPH in the or chronic thrombus of some form in the left lower lobe. It really was the left main and the left upper lobe that was full of sarcoma. But all the other side as well, this is all from the right. And the right doesn't look that badly involved on this. I mean, there's some soft tissue here, but all this stuff on the right, again, I don't even know where it is. That's all sarcoma. All this stuff. So
what's the time between that last CT and the resection?
It was a decent amount of time. It was about 4 months.
Oh, okay.
So yeah, but I thought we had another one. Did I not pull up the right ones? I might have pulled up. Yeah, I thought we had another one, but this was 4 months. So it might just have grown, but I thought we had another CT. Anyways, nonetheless, let me check to see if we had one. I thought we had one more that was closer to pre-op, but didn't show a dramatic amount of stuff in the PA, but I might be wrong there.
So you think those were all just bland clots that were flicking off, or?
Yeah, that's the only thing we could think, because
and then resorbing, and then
Exactly.
And the tumor was just kind of growing along the intima and
Yeah, because
eventually.
or there was the other possibility now is looking on the extent of these that, you know, maybe these were mixed with sarcoma and the clot. I mean, the clot got better, but maybe given the degree of tumor that was on the right, maybe there was actually sarcoma, some cells in this, and they grew, even though the kind of clot disappeared. You know, here's that post anticoagulation, the clots are gone, but there's some new clots. Like this was new.
Yeah, that's
So
interesting.
it was really, we were like, geez, wow, I mean, it looks like sarcoma, but he's clearly throwing clots. And, you know, here's this thing was new too, but we just presumed that given what they saw, we said, we presumed that this must be flicking over. That's the only thing we can explain. But given the amount of tumor on the path, that these must be mixed with clot and tumor. Yeah, it's weird. The more I see of these, the more I realize there's just every variant. You know, here's another acute clot that, and that got better on the follow-up. Those went away. You know, those all went away. So it's just a kind of strange case. Anyways,
So you think everything on the on that that you showed on that picture is tumor?
well, so yeah, let me pull
Tumor and clot mixed up, or just fleshy tumor?
Let me make this bigger. Let me just do Control plus. Can I do that? Does that work? How do I? Anyone know how to see Paint? Anyone know how to make this bigger on Paint?
Is it like Command plus or Control plus or something that?
Control plus, Command plus might do it. Not sure.
I've been trying. It's not working. Anyways, so all the red stuff and this soft tissue stuff, that's all tumor. And all these little black areas, they're like, you know, that's like tumor.
Okay.
Well, it doesn't look like that. Yeah, not all of it. A lot of the white stuff is just intima.
Okay, that makes sense.
Yeah, a lot of the,
so they do like an endarterectomy, and they define a plain section.
Exactly. So they literally dig along inside the vessel and do a circumferential resection of the intima and just pull it out.
Yes.
And this was big tumor in the PA, and this is, you know, but clot is usually just like this stuff looks like clot, these little red dots. But when you start seeing these heaped up soft tissue things like that, they know right away. They're like, oh, that's all tumor. Yeah.
Wow.
That is really cool.
Wow.
All right, guys, those are
all right.
my cases.
Wow, thanks, Seth. All right, Travis and Howard.
Sure, I can go.
All right.
All right, so yeah, this is the case that I saw a couple months ago. And so credit to the outside folks who saw this in the soup sag of the left lower lobe and said, there's some sort of filling defect here. We're not sure if it's PE, don't think it is, but not exactly sure. And even on these images right here, you can see these big intercostal arteries coming off of the aorta. And I'll show you lungs on the subsequent one just to show what the lung parenchyma looks like. And there's another area anteriorly on the right as well that I'll show you. But you know, I don't have a nice systemic arterial phase that like Seth does, but you can see this is a little bit different phase of contrast. And even, and you can see that there's definitely contrast opacification here. It's closer to the aorta, and it follows the aorta on all of these. So this is getting more aortic flow. And then I think this is the most recent one that has the best look at the lungs. But this is what the lung parenchyma looks like in this area. And yeah, this is where these vessels go. I don't know what the best explanation.
This case before?
Yeah.
I remember this. I remember this case.
Yeah.
Okay.
Yeah, so I don't, again, I mean, some sort of prior insult, whether it was, maybe it was infection. I don't know. He's got some collaterals in the chest wall here. And you know, the one thing I realized I didn't point out at the last time is that he has these lateral costal arteries that I know we've mentioned before, and I think this area right here is actually getting fed by a hypertrophied lateral costal artery.
Yeah.
Now, this is a small enough vessel where it's not actually, I don't see a macroscopic communication or enough to cause a difference in flow and some smoke, but yeah, so this is, again, this is the only problem with these, right, is we don't know what's causing them. It's definitely a systemic to pulmonary artery shunt with flow reversal from the higher systemic pressures, but for what cause, I don't know.
Yeah.
Yeah. Wow, that's so good.
All right. This one, so this is the radiograph from last week. So everybody can guess what this lady's presenting symptom was, or you could take a guess.
Could be stimulating a phrenic nerve, or
Yep, the classic presentation of Twiddler syndrome. So she had this placed just 2 months ago, and you can see right atrial lead in the appropriate location. The right ventricular lead's fine, and you're exactly right. Yeah, so a few days ago she began feeling jumping feeling in her right diaphragm. I'm not exactly sure how she would know it's her right diaphragm, but yeah, exactly right there, Howard. So Twiddler syndrome with pacing of the right phrenic nerve. So just a quick radiograph.
You know, Travis, it's
Yeah,
not a lot of rotation of that generator, and it's not your classic like wound up, because there's usually a little
right.
redundancy in there. I wonder, maybe she had a capacious pocket and it's sort of because she's got a lot of soft tissue, and you wonder
Sure.
it was just loose in there. But I mean, I'm trying to figure out how it pulled out that much. I guess.
Yeah. No, and that's a totally fair point. Yeah, I don't know if she was actively twiddling. Like, I know I showed one years ago that the woman was a swimmer, and it must have just been that she had a too large of a pocket, not that she was actively spinning it. Yeah, and you're right. So yeah, I don't know how it migrated, but you're right. Since it was only one lead, it may have been that it's just big pocket looping on itself a little.
right.
So totally fair point.
That's a great case, though. I like it.
This is a really good radiograph. I'll just let you look at it for a moment. So this was a 16-year-old, 100 miles an hour versus a tree, was what the note said. And I think you jump to the left hip hemothorax, layering posteriorly on the supine radiograph. And even with, if you want to say there's some mass effect from the pleural fluid, way too much deviation of the trachea here. You've lost your aortic arch. You have a large apical cap on this side. So the left main stem bronchus is depressed as well, and you may even have some loss of, you can see a nice right-sided paravertebral interface, nothing on the left.
Right.
And then the question was also raised, did it extend over to the right side? But usually brachiocephalic artery injuries or whatnot cause leftward deviation of the trachea. And I'll just show you, this was not a diagnostic dilemma. You'll see the extent of the injury. And I think most of what you're seeing on the right, there's a little bit, maybe the esophagus is displaced a little and there's a little bit of hematoma here, but most of this is just thymus, I think, from him being only 16 years old. The injury itself is right there, and it's a little bit lower than the isthmus, certainly still a traumatic aortic injury and close to that area, but he fortunately was able to undergo endovascular repair and is doing better. I don't know what other injuries there were outside of the thorax, but this is post-stent placement, and some of that is starting to resolve already.
Oh, he's lucky to be alive. Look at that aorta.
Yeah, I know.
Alive.
Yeah. Yeah. So by the time they did the radiograph or the CT, they already had as you can see, there's a pigtail catheter in place. We didn't have an abdominal radiograph. What do you guys think? Do you think there's any component of pneumothorax, like a hemopneumothorax, and perhaps there's a deep sulcus? I wasn't too crazy about it just because the left heart border is not really that sharp. We don't see the fat pad sign like you often see with an anterior pneumothorax.
Right.
Yeah,
So
probably not, but sometimes it's amazing what you hide.
yeah. So this is just like Seth or Jeff, like the case you were showing, the truncus or the TET with pulmonary atresia, and like Seth is saying, it's not uncommon to see these. The story with this one is kind of crazy. This lady is in her late 30s, and she had some remote history of a murmur, but presented to her internist weeks after giving birth to a term baby. She'd gone the entire pregnancy without issue. Weeks after birth has worsening respiratory symptoms, and a radiograph much like this one, you can see this was called just left atrial enlargement and cardiac enlargement, prompted an echo. The echo was interpreted as severe dilation of the left atrium, dilated hypertrophied LV, and they suspected it was probably a pericardium cardiomyopathy. I don't have access to the EMR, but she also had a CT done, and you'll see what the diagnosis really is. And first off, it's a little bit of a wonky arch here. It just looks a little strange. It is left-sided, but as you will quickly notice, the aorta anterior and to the left, and you can see, as is typical with transposition, that the coronaries are more anterior, and the non-coronary cusp, is often, in an unusual location. And you can see this is the right coronary. Well, this is a coronary artery with a portion that goes anteriorly here, and then here's the other coronary artery, and then of course the pulmonary artery right here. So this is in fact an L-transposition rather than a dilated left ventricle. So situs solidus with L looping of the ventricles. This is of course the right ventricle. You can see an apically displaced atrioventricular valve, the separation of the inflow and outflow tracts, and then the muscular conus along the aorta. So this is the embryologic left ventricle going to pulmonary artery, and then going back to the dilated left atrium to the left ventricle, or to the embryologic right ventricle, which is the systemic ventricle, and then L-transposition here, so SLL. So I just thought it was amazing that she was able to make it through a pregnancy, but maybe that just tipped her over the edge, and then she finally presented afterwards. She still wants to get pregnant again. They just did a tricuspid valve replacement in her, or repair. And I don't know what the long-term plan is for her, but it's one of the nicer CTs of this that I've seen.
Yeah.
That is really nice.
Okay.
Don't most
So
of them have conduction anomalies, so they present earlier?
Yeah, and they end up with, the typical thing is when you see it in an adult is to see them with a pacemaker already.
Uh-huh.
Yeah. And yeah, she has not gotten to that point yet.
Wow. All right, thanks. All right, Howard, do you have cases?
Okay.
All right.
This is a patient that developed acute respiratory failure. At this time, of course, the patient has a tracheostomy tube in, and I just got this today, so I can't remember exactly what the etiology of the diffuse lung disease is, but I'm going to show you that they instituted veno-venous ECMO. Now, usually, most of the time, we see a single cannula. The one that the people here use most of the time is the Avalon cannula. So it's a singular cannula, large, via a jugular vein. It has 2 channels for venous ECMO. It's unusual here, at least, to see the dual cannula form of veno-venous ECMO. So one way to do it is, of course, is to put one big cannula via the jugular vein, another cannula up the IVC. In this particular person, we have 2 cannulae that are coming up the IVC, and I'll mag this up. But for trainees, when you see that the tips of the 2 cannulae are only separated by about one or 2 centimeters here, about 2 centimeters, that's too close. So if you're taking in blood, oxygenating it, and putting it back, and the oxygenated blood coming back is going to be pulled right back out via the outflow cannula, that's not good, because you don't have a situation where you can basically deliver the oxygenated blood to the body in the usual sense. So these have to be separated to a greater degree. I don't know that there's a single number, but on the follow-up, they were separated by a greater distance, which is more appropriate. So let's see if I can see it here properly. So there's like one down here and one over here. So they subsequently separated by about 10 centimeters. So again, I don't know if there's a single number, but 2 centimeters is too close. And the term sometimes used is kind of a recirculation phenomenon, or at least a phenomenon where you're not delivering the oxygenated blood to the systemic circulation, because the oxygenated blood is just sucked back out of the other cannula, right? Have any of you guys heard of a particular number or any guidance for that? I think I've seen 10 centimeters or so.
Not specifically, but it makes perfect sense.
Okay.
There should be.
Yeah. So they had to make that adjustment there. This one is really quite odd. So these are post-operative radiographs in a patient with surgical management of an acute aortic dissection, which I'm not showing you here, but the operation was apparently very difficult, very prolonged. And ultimately, at the end of the surgery, the surgeon diagnosed left ventricular failure, had to institute in the operating room central AV ECMO. So related to that, we have a right atrial cannula and a cannula that goes to the aorta. So in reading post-op radiographs, I'll show you, I'll bring this one alongside. It shows the same thing. So I'll just mag it up. Now this is a real kind of a subtle finding, and you have to be familiar with this and be a bit lucky. So on both these exams, one from yesterday, you can see there is a small, really bullet-shaped object right there. And now, having seen it before, I recognize that as the metallic tip of a left ventricular vent. So typically when you institute central AV ECMO and the chest is open, the surgeon will put in a vent via a pulmonary vein threaded down atrium to ventricle. And typically you see that right here in the left ventricular cavity. So that's not in the usual place. So I spoke to the surgeon, and basically the short story is, and I'm not really exactly clear why, but they said they were unable to successfully thread this down all the way to its usual position. And after some time, maybe because of everything else that was going on, they decided to leave the tip of the LV vent in that superior pulmonary vein. And it's still, in a sense, working to some extent. It's still taking some blood out. And the blood that's taken out of the LV vent is basically connected with the Y connector to the atrial cannula. And then, of course, all the blood comes back to the aorta. So malposition, not ideal position of the metallic tip of an LV vent. And that's that small guy right there, just as a point of information. I don't know if there are other brands or products of LV vent that don't have a tip, or a tip that looks different. This is the only one that I've seen, like a little bullet-shaped thing. Okay, here's a really interesting case. So let me give you, by way of introduction, the diagnosis that in this person was made quite a long time ago, as best I can tell. So we have the entity of brachial plexopathy. We have the entity called Parsonage-Turner syndrome, And the other term for this is neuralgic amyotrophy. And we've seen this sporadically in the context of phrenic nerve involvement. Turns out that there is a familial form of this, and I can't remember the name of the gene abnormality that's been associated with the familial form of this entity. But this patient was diagnosed with this entity a long time ago, and apparently a family member, I don't know what symptoms the family member had, suggested that that family member also had findings of this. So typically brachial plexopathy, which involves symptoms related to an upper extremity, of course the brachial plexopathy, but apparently sometimes it can involve other nerves in other parts of the body. One interesting thing about this person is that at some point in time when he had involvement of his arm, he said that he lost sensation in his hand. And on one occasion, he put his hand on a stove or something, didn't realize and couldn't feel it, and burned his hand. So that was one aspect of his history that was interesting. So he comes with that diagnosis, and I had to go to the medical record to find out, because this is just like a sniff test, and then you go and evaluate the patient. So what I typically do, and it can be really helpful, is that before I go do a diaphragm fluoro, I review all the images to try to get the lay of the land, because we don't get any information. Of course, I go to the medical record and try to get information whenever I can as well. So let me show you, just to go back, a chest radiograph here and another one. And let's get the timing between these two. So you can see on both these exams from 2020, 2022, that he's got poor inflation of his lower lungs. The lower lung zones are underinflated, the diaphragms are high. I'll show you a CT from 2020, and alongside it, I'll put a more recent one here. And this, you will see, is one of the more dramatic cases of diffuse muscle atrophy. That's why I was hoping David was here, because if you go to the posterior hemidiaphragms and the crura, that's how thick they are. So he has, and of course where the diaphragm is contiguous with liver, you can't even see it. So this is really helpful. So severe diffuse hemidiaphragm muscle atrophy involving the crura. So of course, even before I did the fluoro, I kind of knew what I was going to see right off the bat. So let me show you fluoro, some images, patient, upright patient, recumbent. Now, recumbent is on this side. So I'll just, let me just play this one. Actually, let me stop this one a second, do this one. So on each of these, you're going to have to try to look at the chest wall, scapulae, clavicles, to get a feel for when the chest wall is moving. And there are a couple of pitfalls with trying to evaluate hemidiaphragm motion. One is relative motion. If you think the diaphragms are moving, they may not be moving much, but it's the chest wall that's moving and the lungs are inflating somewhat. And you might think the diaphragms are moving in the right direction. The other potential pitfall is some patients may adopt a pattern of breathing whereby they actively expire, drive the hemidiaphragms upward, and on the next inspiration, the diaphragms move down, but they just relax down rather than contract down. So here, when the patient is supine, apparently the possibility or the likelihood of them adopting that pattern of breathing is diminished. Sorry about that. And you'll see that on this image, again, you'll see the clavicles lifting up, the chest wall lifting up a little bit, and pretty much no motion of those hemidiaphragms with him recumbent, which is what I was expecting to see given those morphologic findings. So it can be useful to also, as David tells us, to image the patient when the patient's recumbent like that. Now I'm going to show you one last thing. With the patient's permission, I made this recording. So try to ignore this cute suspenders over here. And I'm going to show you the phenomenon of thoracoabdominal paradox. So typically, of course, when you breathe in, your diaphragms descend, your anterior abdominal wall protrudes outward. So when I play this, look at his chest up here, and looking at his shirt here, his abdomen here, look in which direction they move. So I'll play this, say, twice. Hope you can appreciate the chest goes up, but the abdominal wall here goes down. So that's, in my view, a pretty typical thoracoabdominal paradox. So when the chest moves and the lungs inflate, the negative pressure is such that the anterior abdominal wall is drawn inward, which is the opposite of normal. So everything fits very nicely for bilateral paralysis, and he also has thoracoabdominal paradox, as you see here.
That's very neat, Howard. Thanks for doing that video.
Yeah. He's had this a long time. You know, some patients with bilateral paralysis can't really tolerate lying down, but I guess he can adapt. Of course, he's had it for a long time, but he is on oxygen and so on. So I was able to sort of take my time and make some movies and so on, as you see there. All right, those are my cases.
All right, great cases today, everybody. That was really good stuff. All right, well, I will talk to everyone next week.
Okay, bye everyone.
Bye-bye.
Thanks, see you.